Welcome to Health Focus, where we focus on your health. Today we're focusing on work-related injuries. I'm Dr. Scott Anderson, your host, and it's my pleasure to discuss with you today this very important topic with a distinguished guest, Dr. Charles Zeller. Welcome to the set, Dr. Zeller.
Thank you.
And if I may, I'd just like to point out that Dr. Zeller has a distinguished history. He is past president of the Board of Directors of the International Academy of Independent Medical Evaluators. He's also a board-certified orthopedic surgeon with extensive experience in diagnosing and evaluating individuals with work-related injuries. And I should add that although we have different professional environments in which we practice, I tend to go often to UC Davis, for example. We do overlap at times evaluating patients with a company called ExamWorks, so we know each other from that. But I don't believe that there are any conflicts of interest in inviting you to be on the show, and it's such a pleasure to have you here.
Thank you.
And I'd like to start just by asking you a little bit about how you got into evaluating and assessing work-related injuries, and I guess treating them as well in your career as an orthopedist. How did that come your way as a career endeavor?
Basically, in the 1980s, I was a full practicing orthopedic surgeon, and my office staff wanted me out of the office on Wednesdays because I overworked them. So I got an offer to do workers' comp evaluations on Wednesday at a firm that was called Medical Evaluation Specialist, and it has blossomed since then. Since now, I almost do that full time.
It's interesting, isn't it, that if we are talking about injured workers, there is dedicated treatment which can occur in special clinics, often involving occupational medicine doctors. And then there's also an entire separate field of just evaluating people as part of the workers' compensation assessment process.
Yes.
And people who do that, including you and me, were known as qualified medical evaluators.
That is correct, yes.
And what do QMEs do?
We're evaluating workers' compensation injuries for their appropriate treatment, what their disability is, rating them, what they can do, what they're not able to do at work, how much that injury is going to impact their life. Basically, all the injuries that are attributable to their work.
And I think it's fair to say that if we talk about injured workers, about 70 or 80% is going to be orthopedic surgery, right?
Yes.
You know, I mean, people could be injured in other ways. They could have what we call injury to psyche, where perhaps they're traumatized emotionally. They could have internal medicine issues caused by perhaps a toxin in the environment. So there are other specialties, but most of it is orthopedic, right?
The preponderance of workers' compensation claims and treatment is orthopedics.
So maybe, Dr. Zeller, we could start just by discussing the scope of the problem. Would you say that work-related injuries in your field, orthopedics, that they're uncommon, they're fairly common, they're rare, they're super common? What would you say?
They're probably about, in a population, maybe about 10%, about 10 people out of 100 will have a workers' compensation injury. I have seen mostly, the most problems are low back pain, carpal tunnel, shoulder rotation cuff injuries, plantar fasciitis, and tennis elbow or epicondylitis. I think that really is about 80 to 90% of the injuries.
And let's face it, if 10% of people file a claim, there may be another 10% who get hurt and just tough it out.
Correct. Some people just don't report them.
You know,
Yes.
I've seen signs in workplaces that say, day number 98 without an injury. And I've been told by people who work in warehouses and other locations that if you get to a certain number of days, the boss will buy everybody lunch or something. And conversely, if you report an injury, you're kind of stigmatized.
Almost ostracized, yes.
Yeah, you've encountered that, I imagine.
I have, yes. And there's probably some underreporting of injuries, yes.
Well, with respect to back pain, for example, you know, I think that it's pretty well established that about 90% of people will have an episode of acute back pain at least once in their lives.
Yes.
So then the question becomes, and I'm asking you this question, if somebody's working, say in a job with some physical exertion, but not that tough, say a clerk who has to occasionally lift things up and down in a stock room or something, and that person gets back pain, how do you determine if it's a work-related injury?
Many factors go into that. I mean, obviously, if you have a slip and fall and there's an acute injury, that's an easy one, that they hurt their back. Looking at back injuries, and sprains are the most common from lifting or lifting and twisting, you have to look at the whole scenario. How old are they? Are they overweight? Do they smoke? Have they had previous back pain? Do they have previous imaging? Do they have degenerative changes? All that goes into it. If you're examining somebody initially, if we get to see them initially of a back injury, they generally have tightness and spasm. Unfortunately, as a QME, I'm seeing them down the road after they've had treatment for generally 4 or 6 months before they get to me.
So a back injury can be partly industrial and partly non-industrial.
Yes.
What if a back injury is only, say, 10% industrial? Does the employer, does the workers' compensation system still have to provide care?
They do, yes, they do. And at the treatment, you would apportion a percentage of how much you feel is work-related, how much is not work-related.
What does apportioning mean?
It's a percentage saying, let's say 10% of this fellow's injury and his pain is secondary to his work. 90% is because of his age and pre-existent degenerative changes, and he is way overweight. These are all factors that go into the developing chronic back pain.
How high of a percentage of work-related cause has to be present for treatment to be provided through workers' comp?
It's just any one iota, and you would have to treat them.
Even 1%?
1%, yes.
And
that varies for jurisdiction. In California, it is 1%.
because you evaluate in other states, right?
I do, yes I do.
So it's different in, say, I don't know, Texas?
It is.
How is it different generally?
Texas is a very conservative versus California. They will accept treatment, but will stop treatment very early.
So when you evaluate someone for an injury, how sure do you have to be that it's industrially caused before you'll offer that opinion? Do you have to be absolutely certain?
No, but the legal term is more probable than not, and I have to look at their history, whether that correlates well with what you found physically and their records and how their treatment has been and their response to treatment.
So this is a complicated field. Employers, they must be aware of this. Are they taking steps to try to minimize work-related back injuries, for example?
I believe they do, yes. In certain places like Walmart or Home Depot, they want you to wear a supportive back brace. And I believe we see that when you go to Home Depot, that these people are wearing them. They're also instructive in, a lot of companies now have exercise programs to keep you fit and instructing you in appropriate lifting. If you lift and twist, that's particularly bad for your back, lifting and twisting at the same time.
I have spoken to some workers from companies that seem to be on top of this, and they sometimes will describe a morning huddle where they get together and talk about the day, and they'll do some warm-up exercises together and maybe even review safety procedures.
Yes, that's warms up is always good. Your body is like Jell-O. If you heat Jell-O up, it gets nice and soft. If it's cold, it's hard, and you are more apt to have a muscle tear or strain because you don't have the flexibility.
Right, and you mentioned that things like obesity, and let's face it, 2/3 of us are either overweight or obese, so that's a huge problem. Deconditioning, these are issues. And you mentioned, I believe you mentioned smoking,
Yes.
or maybe I mentioned it, but smoking has emerged as a risk factor for back pain, right?
It has, yes, and it hinders the healing potential of your cells. If you are injured, it prolongs the healing.
I've heard that some surgeons are even reluctant to do back surgery on someone until the person quits smoking.
That is correct, yes.
So now let's say somebody does have a work-related injury. That person might be treated and might return to work, right? That's the goal.
That is the goal, yes.
Do you have a sense of how many people are successfully treated and how many don't go back to work?
Well, about 15% of back injuries don't get better in 6 weeks to 8 weeks. That 15% basically eats up about 90% of your work comp dollars. So 85% go back to work fairly quickly. 15% do not and become chronic pain patients or need additional treatment.
You know, I've heard, Dr. Zeller, and I think there might be something to it, that how long you're off work also impacts whether you return to work.
It does.
You know, irrespective of the injury. And if you've been off work for, let us say, a year, that on a practical basis, most people never return to work. Do you agree with that?
They generally will not go back to the same job. They may go back to a sedentary job where they're sitting or maybe a greeter at Walmart, but that is correct. If 1 year they're not back to work, they're not going back to that job.
Do you think technological innovations might really help us with this? I'm thinking, for example, nurses. Nurses hurt their backs a lot, but there are devices like lifts. One of them is called a Hoyer lift.
That is certainly beneficial, yes, if they will use the Hoyer lift, yes.
Mm-hmm. How about in other fields like construction? I don't see quite as much of an advance there, but I don't know.
Again, wearing a protective back brace, not so much for support, but psychologically it reminds you to do appropriate lifting.
Maybe we can shift gears to carpal tunnel syndrome. I think you indicated you see quite a bit of that.
I do.
Tell us what it is.
Carpal tunnel is a condition of a compression of the median nerve in one's wrist, and it generally presents with numbness in your first, second, and third digits. And it's generally, to quote George Carlin, who's a lot of us may not know who George Carlin is anymore. I'm getting old, you know.
I know.
But it's too much stuff in too little place. So you're getting too much stuff in here that is causing the nerve to get compressed.
Now, I remember discussing this with one of our colleagues, Dr. Henry Eddington, and he's a fine physician, happens to be an older gentleman. He's now retired. And we both observed that back in the day, say the 60s, 70s, when you and I were young, people didn't type on keyboards as much as they do today. Maybe you would type on a typewriter, but the ribbon would have to be adjusted. The paper would have to be changed. You can actually type continuously now and never stop. Do you think that plays a causative role in carpal tunnel?
I believe there's some causation of that. There's been some studies that say with continuous typing, and that means 4 hours a day, it'll take you 2,000 hours to develop carpal tunnel.
How about things like, using power tools, driving vehicles, power gripping?
Vibration and, again, operation of chainsaws are directly linked to carpal tunnel, particularly in chainsaw workers and loggers and in quarry marble workers who are using jackhammers. Carpal tunnel is really very prevalent in those two particular vocations.
How can workers protect themselves and prevent this condition from developing?
Wrist rest on a computer, which is the panel that you're resting your wrist on. They say that a division of the keyboard, rather than a straight keyboard, but put your hand in a more functional position, a split keyboard, and there's a vertical mouse have been shown to provide some benefit.
Okay. And you mentioned working with chainsaws and so forth. I'm reminded of some of the scientific literature in my own field of rheumatology that indicates that occupations can also predict distribution of degenerative arthritis, wear and tear arthritis. And for example, individuals who use a jackhammer may get arthritis in the wrist in a manner that's atypical, more like rheumatoid disease. And painters might get it in the shoulder from reaching up above their heads all day, farmers in the hips from bending and lifting. This kind of is in an area that crosses over into orthopedics because now joint replacement surgery often is an option.
Yes.
Do you see a lot of degenerative arthritis in other joints other than, we talked about back pain, we talked about carpal tunnel syndrome, but do you see it as a work-related injury in other joints, and where do you see it?
I do see it in shoulders, where people are doing repetitive lifting overhead, be it stocking a shelf or climbing on ladders, or painters, as you mentioned. I want to mention something about carpal tunnel. It's a little, people always ask me, women are more apt to get carpal tunnel than men. And the reason is why? Now, there's two answers to that. One, I've heard from women, because women do all the work in the world, but women have smaller wrists than men in general. The median nerve is the exact same size. So women have less wiggle room for any inflammation in their wrist than men, and therefore get earlier compression of the median nerve.
Interesting, and it's also interesting to note that what we consider really hard, demanding work is kind of in the eye of the beholder.
Yes.
Because obviously in some fields, such as clerk-related work or typing, or even I would say the hair care industry, fields like that, there's a lot of repetitive extension and flexion of the fingers, but the force is not intense, and yet it occurs throughout the day. I wonder if that results in higher prevalence of median nerve compression in women.
The studies are still out on that. It's generally high force and high repetition that is directly linked to carpal tunnel.
And as an orthopedic surgeon, you have surgical options for carpal tunnel too.
Yes, you do, yes.
How do those work?
They work generally very well if the diagnosis is correct, and basically you're releasing the ligament and basically giving the nerve more space.
Okay. So we've talked about mechanical low back pain, we've talked about carpal tunnel syndrome and degenerative arthritis. You also mentioned tennis elbow?
Yes.
Now, you don't have to play tennis to have tennis elbow.
No, not at all.
So what is it exactly?
When you grip with repetitive gripping, your hand is generally flat. Now when I grip, notice how my fingers come up. That puts stress on the outside of your elbow. And I say it's like you have electrical wire in the wall and you keep pulling on it and pulling on it and pulling on it, and eventually causes irritation on the outside of your elbow, which is epicondylitis. And you see that in people who are doing gripping and twisting. I see a lot of it in correctional officers who have heavy keys, opening and closing doors, and they have those huge keys that are turning the doors. I see a lot of that in prison workers, correctional officers.
I remember those keys from when I worked in corrections. They're called Folger Adams keys, and they look like they're out of an old Western movie. They're this big. Yes, I can imagine that. And in terms of soft tissue issues, you can also get medial condylitis. Some people call it golfer's elbow.
Yes.
That's on the inside of the elbow.
That is correct, and that's from repetitive flexion. Much less common than lateral epicondylitis.
And how do you treat these conditions?
I like to treat them with a wrist splint. A lot of people will put them with a band here, which stops the muscle from its point of force on the elbow, but you have to wear that band so tight that it generally cuts off your circulation. I like them to wear a wrist splint because then they can't do this or that.
Okay, changing gears, there are a few conditions that are poorly understood, and doctors often disagree about them and render opinions. Maybe I can ask you about them. One is long COVID with soft tissue pain. People who had a COVID infection, they get over it, and they still have pain in their joints. I see it as a rheumatologist. Do you encounter that?
Very rarely, and I must say I would defer that to your specialty.
Okay. Do you have any thoughts on, for example, fibromyalgia?
Fibromyalgia is general muscular pain, and we do see that, and there is no specific etiology or test to diagnose that. You generally do see that, and some people have just a proclivity to that. I believe that's just due to their psychic makeup.
Okay. I realize that's a controversial topic, but I appreciate your insights on that. Let me ask about prevention. Let's say that I'm feeling great. I'm in the top health of my life. I'm a young person working in a job. Can you give advice just on how to avoid ending up coming in to see Dr. Zeller for a work-related injury?
Appropriate lifting techniques. If you start to get pain in the joint from a specific activity, alter that activity. If you start to get pain in your back with sitting too long, get up and stretch. Try to keep active outside of work if you have to take a walk every day. Of course, cut down on smoking and alcohol.
Okay, when a person is injured on the job, how does that person proceed to consider filing a claim? Let's say it's a mild injury. Does the person just tell his or her supervisor?
Either their supervisor or their safety officer.
And then what happens?
And they should establish a claim, and they will send you to whichever primary doctor they are contracted with. They send you to a clinic.
I believe usually they send you to a clinic that is dedicated to treating injured workers, but I think in some jobs you can choose your treating physician in advance.
Yes.
And if they say they're going to send you to a clinic and you get treated and you're okay, then that's the end of the story.
Correct.
What if you're not getting better? What do you do next as an injured worker?
If you not get better and the treatment is prolonged, you should ask for a qualified medical evaluator. And sometimes if you may want to get an attorney to help your claim.
And if I'm not mistaken, in fact, you can even ask your physician to file a form. I think it's called the Doctor's Report of Occupational Injury or Illness, and that could start the ball rolling for that.
That is correct.
But I should also share, and I suspect you'll agree with me, that this is always a double-edged sword, because once you let your treating doctor know that you're filing a claim for workers' comp, 99% of the time the treating doctor is not going to want to treat you anymore.
That is correct. They're going to refer you to an occupational medicine clinic.
So it's a tough decision, but on the other hand, if you don't do that, you may not get the treatment you need.
Correct.
So here's another question, which is, I think, kind of tough, but I'll have you take a crack at it anyway. At what point in that process should the injured worker consider getting an attorney?
That's a tough one to answer, and I'd rather not say, but I would say if you're getting frustrated with the system, you're not getting anywhere, you feel the doctor's not listening to you, you get an attorney and they will refer you to another physician.
Yeah, I think it is a tough question because it's a matter of individual choice, and also neither you nor I are attorneys, so it's kind of hard to comment on it. But that sounds like a reasonable thing to say. Let's talk about a few high-risk occupations. I'm talking about first responders like police officers and firefighters. Is evaluating them different in any respect when it comes to your job as an orthopedic surgeon, as a QME?
I do see probably more musculoskeletal injuries in both police officers, correctional officers, and in firemen from the nature of their work, which can be quite vigorous. The pulling hoses, being on inclines, altercation with perpetrators.
Yeah, I've had the same experience. I think, for example, firefighters lift these 200-pound ladders and they blow out their shoulders. They also get a lot of hernias, which is not necessarily orthopedic. And of course, as you know, when it comes to police officers, they're actually putting their lives on the line, trying to make arrests and struggling with people. So, yeah, there's a lot there.
And I'm a little biased since my father was a fireman for 40 years in New York City.
Oh, well, that's understandable. Yeah, I think we all feel a certain desire to do the right thing when it comes to individuals who put their lives on the line for us. We're beginning to run a little short of time. Is there research in orthopedics, either on prevention or treatment of work-related injuries in your specialty?
There's a lot of research, especially on carpal tunnel and prevention in carpal tunnel. And that is getting to be very prevalent in the United States.
So the workplace is having older people in it more and more.
Yes.
I think by age 65 in the U.S., about 80% of people are retired. But still, there's a significant minority of people who work into old age. Do you encounter them at all? Are they a particular challenge for you?
Well, I'm one of them.
You and me both. But let's face it, we're working in usually an air-conditioned clinic and so forth. Maybe not all the time. And I guess actually surgeons put their body under a lot of stress. Now that you mentioned it, being a surgeon can cause a lot of joint problems, right?
Yes, it can. Yes, it can. Older people generally have arthritis just from their age.
Right.
And if you're doing vigorous activity or even a lighter activity repetitively, that can, we say, light up the underlying arthritis. You may not have had symptoms before, but now when you do something, it does hurt. So you do see that.
Do you see any future changes in public policy that might affect the workers' compensation process?
I have no comment on that. I'm sorry.
It's hard to know. I know they change the guidelines from time to time. If anyone in the viewing audience wishes to contact you for an assessment, how could they do that if they wish to have a QME evaluation?
My last name is Zeller, Xeller 007 at AOL.com, and don't make fun, it's AOL. I'm one of the original users of AOL.
Well, fantastic. Well, Dr. Charles Zeller, it has been such a pleasure to have you here on the show and to know you as a friend and colleague. And I think that this is a subject that is going to go on and on in terms of importance to our viewing audience. I think we all want to stay healthy. We want to work, if we choose to work, without injuries. But it's important to kind of have a sense of what injuries we may have and how to prevent them. And I think pointing out that about 80% of the injuries are orthopedic is really an important take-home message. And the other take-home message I got from you is that we don't want to neglect our overall health in general. We want to stay as fit as we can and avoid smoking and avoid injuring ourselves away from the job. So hopefully this show will do some good and maybe even prevent a few injuries.
I hope so, and thank you for having me.
Well, it's been such a pleasure.
Thank
I hope
you.
we can continue
All right,
this
thank
conversation
you.
in the future.
Okay.
Remember, here at Health Focus, we focus on your health. Today we focused on work-related injuries with Dr. Charles Zeller. And hopefully you'll stay healthy out there and won't get injured. And if you have any questions, take them up with your treating physician. Thank you so much for joining us, and have a pleasant rest of your day.